there he did his residency at Vanderbilt University. And he's now doing a fellowship in nephrology here at Duke and is one of our research fellows. And we're very excited and happy that he's been willing to give us this conversation and educational program on hypertension. Thanks.
Thank you, Dr. Piper. I did pronounce that right? Piper?
That's Pieper.
Pieper, see, okay. Now we're even, okay. So good morning, and thank you for all of you for joining us. As Dr. Pieper mentioned, I am currently a second-year nephrology fellow here at Duke, also now a first-year fellow with the DCRI. And so with this topic, hypertension, certainly we do address that somewhat with my field in nephrology, but I'm one of many different specialties or specialists that could probably talk about it, and we all have a different take on hypertension, so I can offer you some information on what I know, and certainly we can go from there. Just to point out here, I don't have any disclosures related to the content of this talk. And here's an overview of what we'll be discussing today. We will talk about the hypertension epidemic. We'll discuss the measurement of blood pressure, how we do it, and we'll define hypertension and some other abnormal blood pressure categories. And we'll also discuss some of the cornerstones in hypertension management. And at the end of all this, we'll touch on some of the current controversy and questions out there in optimally managing blood pressure. And so to begin here with the hypertension epidemic, it's not an exaggeration. As you'll see, it's a pretty big deal. So this here demonstrates how profound this epidemic is. This is data from 2011 from the CDC, and in fact, this is actually self-reported hypertension, and so this is probably, if anything, an underestimate of the real problem. This is prevalence of hypertension here by state, and you can see there's a lot of these darker red shades, which is a bad thing in this case. Especially here in the southeastern U.S., there's many states here with upwards of 30% or even up to 35% or more prevalence of hypertension. And don't let the light colors deceive you either, even if you can read the small print on the scale there. That's the lighter shaded states. That's at least a 25% reported prevalence of hypertension in all those areas as well. So clearly a nationwide problem, and again, probably an underestimate here on this map. And just a few other vital statistics on how big the problem is. Across the U.S., that's of course roughly about 30% or more of adults are affected by this. As we'll touch on later, in many cases, the hypertension will be unknown or undiagnosed. And worse off, despite our increased awareness of this problem and public health efforts to prevent it, we're still seeing no significant change in the prevalence of hypertension. And if anything, though, what we're at least seeing with some of this improved awareness is some improved control of hypertension, maybe at least a better job of getting blood pressure under a better control. But despite all that progress we've made, we do recognize that some significant demographic disparities are still out there, and that can stem from just limited access to health care for proper diagnosis and management of hypertension, particularly in African American populations and Hispanics as well. And to go through some basics here, what exactly is blood pressure and how do we develop hypertension? Well, our body actually works to maintain enough blood flow to all the organs, and that includes some very close attention to things like our brain, our heart, our kidneys, and as you can imagine, there'll be a lot of important organs that get the blood that they need, and that value of the blood pressure needs to be high enough so that those organs get the blood that they need to work properly. And the blood pressure itself is a reflection of how much blood the heart is pumping, or cardiac output, and also a reflection of the resistance provided by blood vessels, or this fancier term, systemic vascular resistance. And so blood pressure overall is going to be determined by a number of things. Changes in our environment are going to result in some changes in the blood pressure. There's a lot of complex interplay way beyond the scope of this talk involving the nervous system, various hormone systems, and the volume of blood itself. And when blood pressure is persistently high and stays high, that's when we get hypertension. And some of that too can be related to genetic factors as well. And so what actually causes hypertension? Well, for about 95% of the people that are affected, we call this essential or primary hypertension. And this is probably from some combination of environmental and genetic factors. I've listed some of them here. I think some of the key ones that I want to really point out here are age. So there is an association that changes happen in the blood vessels over time as we age, with increased resistance that will, of course, by that equation I showed you before, raise the blood pressure. There's also, you'll see an abundance of lifestyle factors that have been associated with higher rates of higher blood pressure, things like a higher sodium diet, alcohol consumption, physical inactivity. And these are things, of course, that are things that can be potentially modified and certainly play a role in how we address hypertension when we diagnose it. For a smaller portion of the population, this is going to be a secondary hypertension as the cause, and there are certain medical conditions or exposures that may increase blood pressure, and I've listed some of them here as well, highlighting a few of the key ones and more common ones that we see. Many people that are on either prescription or over-the-counter medications, things that we ourselves may take, day in and day out, Advil, other NSAIDs, oral decongestants that are available over the counter, things like Sudafed. If you're taking steroids for any reason, if you're on anything like cyclosporin, if you have an organ transplant, these are things that all can raise our blood pressure, and in a small percentage of people may be responsible for their hypertension. Certain substance use like cocaine and methamphetamines can raise blood pressure. A big one here that we're maybe becoming more increasingly aware of is obstructive sleep apnea and just how prevalent that is in the population. And if there's hypertension that's a little bit hard to manage, that may be a cause for some people, and certainly something that we're noticing more and more. Just a note here as well that we do see secondary hypertension either from primary kidney disease or from diseases that develop in blood vessels that provide blood to the kidneys. And we've also see hypertension arising from a variety of endocrine and hormonal disorders, a long list that I've listed here. These are not completely rare things. You probably know someone or some people that have these conditions as well. Why do we care, and what really is the big deal with hypertension? Why am I even talking about it for this morning's talk? Many people that have hypertension feel fine. They may not know that they even have hypertension. They don't have symptoms. But untreated and unmanaged hypertension can lead to lots of medical complications down the road, and some of them are very, very serious. There is a high risk of stroke. That's either from a lack of blood flow to parts of the brain or from hemorrhage. And hypertension, in fact, is the most important risk factor for both of those types of stroke. Certainly, long-term, there can be complications to the eyes, what we refer to as hypertensive retinopathy. And this results from changes in the blood vessels that supply blood to the eye. And at very high blood pressures, both short-term and long-term, this can result in a lot of big complications to the eye and can lead to vision changes. We also are very much on the lookout for complications to the heart and to the cardiovascular system from uncontrolled hypertension. So even in early stages, there can be structural changes to the heart. This can result in ventricular hypertrophy, which of course increases risk for a lot of other problems down the road. Hypertension can also be a risk factor for heart attacks and heart failure. And additionally, of course, a very close personal interest to me is and very relevant to my work day to day. Hypertension over the long term can also lead to kidney damage and chronic kidney disease. And if severe enough, and if progression of the kidney disease enough to a point of end-stage kidney disease, it can result in a need for dialysis. And so we'll talk a little bit more about how we measure blood pressure. Obviously, we have reasons to be concerned about hypertension, and before we go into definitions and such, I think it's important for us to understand how it's measured and how it should be measured so that we can accurately diagnose. So a lot of different ways that we can check blood pressure. One of them is with one of these more traditional devices that we see in the doctor's office, the sphygmomanometer, this sort of manual blood pressure monitor that we see here. Has a valve, has a bulb that we squeeze to have the cuff inflate. And with these devices, you would need the use of a stethoscope, or the person checking the blood pressure would need the stethoscope to listen for various sounds that I'll be reviewing shortly. Something a little more common nowadays is the use of an automatic blood pressure monitor. This is how a lot of people sort of keep an eye on their blood pressure at home. And these are some examples of the electronic or automatic blood pressure monitors. So the one on the right is probably the more familiar type of model. It's got that cuff that you place on your upper arm, and there's a display with 3 numbers there. The top number being that systolic blood pressure number. The middle number is the diastolic blood pressure number. It's those 2 numbers that we often think of when we get a blood pressure reading. That third number can just confuse people, if anything, but that's really the heart rate, and that shows up on that display as well. On the left side is the less popular wristband or wrist blood pressure machine. And you may question if that's even a good measure of blood pressure. We're checking it on a different part of the body, but it's actually, unless a person is very overweight or has complications to that particular arm, whether from some prior surgery or such. It actually is considered pretty reliable of a measure. There is a different type of device, aside from the ones I've already shown you, that I'll touch on shortly, that we can use outside the clinic as well. And what do we do once we have, our device, and particularly if we're going to use the manual blood pressure monitor? There's certain things that we want to be able to detect when we're checking blood pressure to know what the blood pressure is. This is just an example here of the real old school. Got the mercury meter there, and when we have our stethoscope, we are squeezing the bulb to inflate the cuff, and initially we want to get that mercury high enough, a little higher than we think that blood pressure is going to be, because at some point we need to hear a difference, that we need to be able to hear a sound. That sound's going to first be heard representing the systolic blood pressure. That's really the peak blood pressure that occurs when the heart is contracting and the artery is starting to open and close, and that's when we start hearing those sounds. When those sounds disappear, that's when the artery has now remained open and the sound goes away. That's our diastolic blood pressure, that lower number. That represents the minimal blood pressure that happens when the heart is relaxing in between beats. And so, again, if you were to even just minutes apart recheck someone's blood pressure, you might get slightly different numbers, depending on what is happening at that very moment in time. And there's a lot of guidelines we need to, use in making sure we're getting an accurate measurement, and a lot of things that we need to be aware of. You can imagine the incorrect blood pressure that you're getting, whether it's either artificially very high or very low. That can, scare people. That can lead to a lot of other questions about what's going on. So we want that person to be at rest, seated for 5 or more minutes. You can already think to your own doctor's appointments, how often does it really happen? Are you really sitting down for 5 minutes? I can't think of a time that's actually happened. And a few other factors that we're looking for is that if we're going to be putting the blood pressure cuff on the upper arm, when the upper arm needs to be completely bare, there can't be a sleeve there can't be another piece of clothing kind of in the way, and that's tough too. And every time I am checking someone's blood pressure manually, they're always wearing like 4 layers of clothing, and so it's a bit of an inconvenience, but it's important to get an accurate reading. We want to make sure the arm is supported, as I'll show you in an example shortly. If the person who's checking the blood pressure, if they can support the arm, and what you want to do is not have it just kind of flopping at the side. You want to make sure it's properly supported, not by the person that you're checking the blood pressure on, but by the person that's actually checking it, so that person who's getting the blood pressure checked can be relaxed. It's ideal to have the blood pressure cuff at the level of the heart, so not down here. You want it, again, to be sort of this natural position where the person doesn't have to stretch or do anything different to do things that may alter their actual blood pressure. Now, the back should be supported, and it's important to have the feet kind of flat on the ground. And I never actually knew the exact reasons for that, but I assume it's not, so that the feet are dangling and potentially altering that reading. And this is maybe one example of the proper the physician and patient setup here to check a blood pressure. Or is it? I mean, is this really the best way to check? And we'll give a little report card here. So we'll assume that she's been sitting for at least 5 minutes and she is seated, so I guess that's a check mark. I don't know, I guess that sleeve is not overlapping where the cuff is. Maybe the upper arm is bare there. I'm not too sure. That's full credit for that. You can see the physician is supporting the arm very well, and so she'll get a point for that one. We're at the level of the heart, roughly, so I think that's good. I don't see her back supported very well. Maybe she just has really good posture. I'm not sure, but I think that could be maybe a little bit better. And we'll assume that her feet are flat on the ground. Maybe there's a step still underneath. But just this, I think, is pointing out that I'm overanalyzing this a little bit, but this is just how complicated and how tough it is to get like the accurate best blood pressure that we can get. And this is after what I think is a decent attempt at meeting all those check marks. This is just raising a bunch of questions of how many of those readings in clinic are really all that accurate when we're checking them. We have to be mindful of a few other things when we're checking blood pressure. So ideally a nice quiet warm setting, relaxing. Any other kind of environment may be a little bit tough to get to that point, but we also want to make sure we haven't done anything that's going to potentially raise our blood pressure. The 30 or 60 minutes before that reading, ideally we wouldn't have smoked. Hopefully free of oral decongestants, things that can also raise that blood pressure by a couple of points. Maybe you had a coffee on the way into your appointment that may alter that number just a little bit too. So again, things that we just want to recognize. So one of the challenges, of course, is just looking at this cuff is just like, well, how do I know that this cuff is the right size for me? And that's probably one of the most common questions that I get when I'm mainly checking a blood pressure. They're saying, this cuff doesn't seem right. And I often tend to be in the room either with the power lifter cuff that's like this big or the cuff that's this small. And so these are always reasonable questions to get. You want to be able to find the bladder of the blood pressure cuff, the part that's going to inflate when you are pressing on the bulb. So usually that's kind of well demarcated with a little white line there that you can see there. And ideally you'd want that blood pressure cuff bladder to be about 80% the size of the upper arm circumference. You don't want it to be dramatically, bigger or smaller in one way or the other. And the width tends to be sort of a preset thing based on the length of the cuff, but these are just sort of ballpark estimates of what we like the cuff to be relative to the person's arm to know that we're getting at least an accurate blood pressure reading. And when we're doing it manually, we want to be able to inflate that blood pressure cuff quickly, and at least 20 millimeters of mercury above the systolic blood pressure that we think. So maybe if we suspect they're going to have very high blood pressure, I may squeeze a little bit harder and get it a little higher, and it may make the person uncomfortable for a moment, but I like to get an accurate reading. And you'll notice a lot of times people are checking the pulses as they do that. They may be able to feel a loss of that radial pulse in their wrist, and that is a sign to them that they should maybe go 1 or 2 pumps higher and start to let the thing come down after they're not putting pressure anymore, and let to pump it up. Maybe you as the patient have watched and seen that number kind of go down a couple points at a time, and usually you want to have that done gradually. So if it's being done really quickly, that might not be the best reading. I like to take my time with it as I'm doing it manually. I have the stethoscope there to listen for those sounds that I described a few moments ago. And if I have just one blood pressure reading, is that really fair to diagnose somebody with hypertension if I think it's high? I'll give you one example. 3 years ago, maybe a day like today, it was kind of cloudy, maybe a little rainy. I was running and I fell and broke my arm. And went to the ER, and I think it was maybe right after a series of 8 x-rays, contorting my arm in the worst possible positions, and I was in so much pain. And they took my blood pressure right after that. So as you can imagine, my blood pressure maybe wasn't that accurate. I was really hurting, and it was a little bit on the high side, and none of us panicked because it was one circumstance, it was one event, one blood pressure reading. And that's not how we necessarily make that diagnosis of hypertension. And I mention that as an example to say that even with just one clinic visit or one reading at one visit, we can't make that call just with that one reading by itself. So a lot of times at each clinic visit, I tend to, in addition to what that person checks, and I even check a manual blood pressure anyways, I get at least 2 readings at one visit. That gives me a better sense of what's happening. More often than not, my reading on the manual cuff after they've rested for 5 minutes, sat down, maybe stopped drinking their coffee, it's a little bit more of a reasonable number if it looked a little bit high when they first were checking in and were being raced in from the waiting room. It's often helpful to check the blood pressure in each arm. A lot of times I'll go with the arm reading that's a little bit higher and use that as the one that I use to say what someone's blood pressure is. And to really make a diagnosis of hypertension, we're going to go into some specifics on that shortly, but I don't want to just use one visit. If someone's got a high blood pressure and this is new, I want to get them back to clinic probably within a couple weeks, maybe even stretch it out to 2 to 4 weeks, maybe about a month time. And I want to be able to make this call on multiple visits, that the blood pressure continues to be high on multiple visits, not just one. And I think that's usually better grounds to make the diagnosis of hypertension. And it might eliminate the incidents like I had where I was walking with a broken arm. So, maybe it was a stressful day for that person. Maybe they were in a lot of traffic, and maybe is that one visit really that accurate? So just things that we like to keep in mind when we're making this assessment. The last thing I'll touch on here is that there are, in addition to these automatic and manual blood pressure monitors, there's an ambulatory blood pressure monitor that's has a lot of utility when we're not in the hospital or clinic setting. Our blood pressure varies day and night. And that even is the case if we're working a night shift. Okay, there's just 24-hour sort of circadian variations in our blood pressure. And this has been very well studied and described in a lot of the literature. This may be helpful for us in the instance that I gave you if we're concerned that somebody's blood pressure readings in clinic might not be accurate or might not be reflective. Checking a 24-hour blood pressure with one of these ambulatory monitors that you can see there in the picture may give us a better sense of what's really happening in those other 23 and a half hours that they're not in our clinic appointment. So this can give us very vital information on what the 24-hour average of blood pressure is, what the daytime average is, what the nighttime average is. And as you'll see shortly, we can draw certain conclusions based on those numbers at different times of the day and potentially detect things that we wouldn't otherwise detect in the clinic. I've listed here a couple of the things that we look at. So the International Database of Ambulatory Blood Pressure in relation to cardiovascular outcome, IDACO, they've set sort of requirements of how many readings we need over that 24-hour interval to really make a call. Kind of how I said in clinic, I don't just take one value to diagnose someone as hypertension. To have anything meaningful from this 24-hour monitor, we want to have multiple readings. And so if there's any malfunction with this and we get one reading over 24 hours, that doesn't really help us. We like to know that there's enough blood pressure readings to really know what's happening for some individual over 24 hours. This monitor also will be able to account for some of those fixed time intervals that happen. There's transition periods in our blood pressure. As I mentioned, it varies between day and night. And there's well-documented periods of time, kind of early morning and late evening, where our blood pressure makes huge changes. And so with some of the technology now, we can eliminate those time periods to, again, get a sense of what someone's daytime and nighttime blood pressure is doing. The information from all this data that we're gathering with the 24-hour monitor can be a very good indicator of long-term cardiovascular disease risk, and that, of course, has been extensively studied in the literature as well, and so we have some science behind that. And these numbers actually are better, they better correlate with some of the complications of hypertension to certain organ systems better than, say, the clinic blood pressure where I'm stressed out because I couldn't find a parking spot and I have a broken arm. And one other thing that I'll talk about is what we look for. As I mentioned, our blood pressure does vary between day and night, and something that we look for that most of us have is this normal pattern of blood pressure dipping at nighttime. Again, whether we're working or sleeping, our blood pressure should take a normal dip. And variations from that can give us additional clues about what could be going on and what risks people might be at that they might not even know. So we'll talk about what we do to define hypertension and what some of these criteria are. So this definition's been suggested at least in 2003 by the Joint National Committee. This was the JNC7 meeting. There was a more recent one in 2014, and these recommendations were, are sort of looking at a couple of things here. They're basing this on the average of at least 2 properly measured blood pressure readings at each of 2 or more office visits after an initial screening. So again, that gets us to the minimum of 3 visits that I talked about. Normal blood pressure that you see here, I don't want to fixate entirely on the numbers, but what we often refer to as normal is less than 120 and less than 80. And I think before I go further on that, it's not always healthy, as you can imagine, to have blood pressure that's much, much lower than those numbers. We need a certain amount of blood flow to all of our organs, and so we have to be on the lookout for blood pressure that's completely on the other side of that, that's too low. When someone has blood pressure, either in the systolic or diastolic ranges that runs a little bit higher than those normal ranges, we label that as pre-hypertension. It causes a little bit of panic, as you can imagine. It's just something that we at least want to be aware of in an individual, and to be on the lookout for the diagnosis of hypertension later in life, and it may be a little bit of an impetus to recommend certain lifestyle changes to sort of minimize that risk of becoming hypertensive. They've also separated hypertension into stage 1 and stage 2. And the rule generally is that if you have one number in either the systolic or diastolic that, basically pick the highest category, you jump up to that category. So if your lower number, the diastolic, is over 100, you're considered stage 2 hypertension. And so just some of the cutoffs that they've provided here, this in some ways can actually guide what we do with management of blood pressure. If someone's blood pressure continues to be in stage 2, we may want to be more aggressive at what we do with medications and other interventions to try to lower that blood pressure. So home blood pressure, of course, if we've got one of those ambulatory monitors or one of those home automatic blood pressure cuffs, we may need to use slightly different rules because in general it's going to be a little bit of a different setting, and what we're doing 23 hours of the day outside a clinic might be a little bit different than what we're doing when we're in the doctor's office. And as the reasons that I've already touched on, you're late to your clinic appointment because traffic looked like this. This is usually the way it is when I'm going to a doctor's appointment. And then finally you get to the parking lot and you're like, oh, sigh of relief, like I'm here, I don't have to deal with this anymore. And then you get this notice that you have to, there's no parking spot, and this is a complaint I get all the time when I'm at the VA seeing patients, is there's never parking available. And so I have to take that with any blood pressure reading that I get with a grain of salt. And then they say, relax, just go in this nice comfy room, go sit on a table and relax. And it's as you can imagine, this is just a different setting. And so we get a lot of utility by looking at blood pressure at home and not just in the clinic. And because of that, the European Society of Hypertension has put a different set of numbers of what is hypertension, and whether it's daytime or nighttime. If your readings on your home blood pressure monitor are averaging above these cutoffs, then you technically meet criteria for hypertension as well. And so that's for daytime, an average of at least 135 systolic or 85 diastolic. Nighttime, greater than 120 or greater than 70 diastolic. And then for a 24-hour blood pressure average of greater than 130 or diastolic greater than 80. So just something, again, to be mindful of, that there are at least different cutoffs outside the clinic room. A lot of other things we need to be on the lookout for, and just at least to understand some of the terminology. If your blood pressure is consistently elevated on clinic readings, but you get one of those home monitors and it's actually not meeting the criteria, we may have a different name for what you have. I think it's easy on this table to classify what normal tension or normal blood pressure is based on what I've told you. Sustained hypertension, you're high in the clinic and you're high at home. If you're high in the clinic but you're normal at home, that's a white coat hypertension, and a lot of people probably are familiar with that. They know someone who has it or who says they have it, or they feel like they might have it. And sort of the scenario that I gave you with driving to clinic and being in that waiting room, and that's just, for some people, that does create a stress response that will raise their blood pressure when they're not in that environment 23 hours of the day, that they don't have the hypertension otherwise. But there's another type of hypertension that we should be mindful of. I've left a box out of here. So that's for people that maybe they go to clinic and everything looks great, but then they go home and their blood pressure's high at home, and nobody knows about this high blood pressure that's there for 22, 23 hours of the day. This is masked hypertension. This is a concern because we're not picking this up in the clinic, and unless they have a home monitor and unless they're going back and looking at these cutoffs, they may not know that they have high blood pressure. But the literature and various studies have shown that individuals with masked hypertension are at a higher risk for cardiovascular disease events long term, so heart disease, stroke. They're at higher risk, and they may not even know it. Ambulatory monitors also give us an indication of how much that blood pressure is dipping at night. So as I mentioned, it's normal for our blood pressure to actually dip at nighttime no matter what we're doing. That's just part of our circadian rhythm. I don't want to focus too much on the math here, but I want to touch on the fact that there are sort of different categories they've put people in based on how much their blood pressure dips. To tell you what I mean by dip, that's your daytime either systolic or diastolic blood pressure. The difference between that and your nighttime systolic or diastolic blood pressure. So that difference, divide that by what your daytime systolic or diastolic blood pressure is, and that leaves you with a percentage. If you're considered normal, your blood pressure should be dipping by at least 10% between daytime and nighttime, okay? So when they have someone who's got at least a 10%, but maybe within a reasonable range that's dipping by less than 20%, they call that person a dipper, and that's considered normal. It's kind of a funny name, but as far as that and people that may be extreme dippers, if they're greater than 20%, I don't know why they said extreme, like they're into like snowboarding or like bungee jumping, but they have this very big difference between daytime and nighttime blood pressure. And studies have shown that cardiovascular disease risk, mortality, it's the same, like whether you're an extreme dipper or a dipper. The point is your blood pressure is dipping enough, and that's a good, it's a good thing. That's what you want. But I've left some blanks here. So as you can imagine, there's people that don't meet these requirements for normal blood pressure dipping, and those are the ones that we worry about. So I'll caution you, I'm not, when I grew up in New York State, so if I see a yellow light, I think that means I'm supposed to drive really, really fast, like really, really fast, and try to make it before it turns red. But yellow light here, this is bad. You don't want to be a non-dipper. So technically your blood pressure is dipping a little bit. It's less than 10% though, so it's not enough. So you're not normal. Studies have shown that this is associated with a higher risk of mortality, particularly cardiovascular disease risk in those whose blood pressure is not dipping by that 10% margin. And some people don't even see that dip at all. Maybe their blood pressure actually goes up at nighttime. And so these are the folks that are going to be at the highest risk for mortality, and particularly mortality from heart disease, what we call these reverse dippers. And so again, these 24-hour monitors can reveal to us things that we didn't even know about somebody, that perhaps they're at a higher risk, cardiovascular disease risk than we would otherwise know. Maybe we don't even know they have hypertension, but this reveals to us that they still may have that higher risk, and that we should be watching their blood pressure closely and thinking of ways to help improve that risk. And with that 24-hour monitor, we also have to be on the lookout for, with these daytime and nighttime parameters and cutoffs I've given you, again, looking very different from that 140/90 that we were seeing in clinic. Some people have isolated spurts of hypertension either in the daytime, which more likely than not, if you're having it in the daytime, someone's going to catch it when you're in clinic. The other concern, though, is if you're just isolated nocturnal hypertension when you're going to bed and your blood pressure is remaining high, but you're not finding it when you go to your clinic appointments. And so this is also associated with a higher risk of mortality and cardiovascular disease risk. So again, another concerning sort of label, condition or diagnosis that we want to, again, potentially pick up on 24-hour monitoring that we wouldn't otherwise know that these people are at higher risk. A few other things that we should be aware of is that hypertension can become severe in some cases. And so someone may have a sustained high blood pressure, but if it ever gets really high, we have to be worried about sort of short-term immediate complications that can happen. I gave you that diagram in the beginning of things like stroke, eye disease, heart disease, kidney disease. Long-term, you're at risk for that. But if at any moment your blood pressure is really high, what we will classify as hypertensive urgency, a systolic of greater than 180 or diastolic of greater than or equal to 120, you're at risk for some pretty serious things. This tends to be something that we see more common in individuals who maybe have limited adherence to their blood pressure medications. They forget to take a dose here and there. They run out of their medications. They don't call for a refill. This is a higher, chance that we're going to see this in someone like that. They often may be asymptomatic with blood pressures this high. They may have blood pressure like this every day and not even know it. Some people do get a mild headache, but otherwise, in this designation of hypertensive urgency, the person may not be aware, but they are at risk for further complications and organ damage if this is not controlled quickly. Hypertensive emergency is when this reaches a different, in addition to the high blood pressure, they're noticing things. Now they have symptoms. So they may have what we call hypertensive encephalopathy. They're not acting like themselves. They're confused. They may have acute vision changes with the retinopathy that can develop with really high blood pressures. They can get very serious acute cardiac issues. They can get an acute heart attack. They could have damage to their aorta that could actually result in an aortic dissection with really high blood pressures. People can develop acute heart failure. And kidney failure, of course, can happen with really high blood pressures, even in the short term. And so those tend to be, if I'm in the emergency room evaluating someone, these are things that I'm looking at to see if they're having any acute manifestations from their high blood pressure. And this does need immediate treatment. Typically with an IV medicine, it needs to be something very closely monitored. And one of the reasons for that is we don't want to drag these people's blood pressure from something like 200 all the way down right away. There has to be a little bit of gradual movement in that blood pressure, because lowering it way too quickly can also result in some serious consequences. And so that's why they need the close monitoring when they have a serious condition like this. And I've touched a little bit on the management of hypertension, but that's more for those extremes. I'll talk about what we do for someone in clinic that come back a second time, a third time, the blood pressure's still high. Now what do we do? Well, I think the key in managing hypertension is first being able to detect it. So the U.S. Preventive Services Task Force does recommend screening all individuals at least 18 years of age. Now, if you're over 40, that should be at least annual. So presumably, if you're going to your annual checkup, that's recommended. That's something that's being checked each time that you go for your annual checkup. If you're 18 to 39, if you have risk factors for hypertension, if you're very overweight or you have a family history or something, you might want to be screening that annually. Or if their blood pressure was kind of on the higher end of that pre-hypertensive range that I showed you before, that may be a reason just to check this more frequently. This is recommended to be checked at least every 3 years in someone who's otherwise very healthy. Maybe they have normal blood pressures on the past readings, and they're less than 40 years of age. That can be done a little bit less frequently. Now, we have to do other things when we're first diagnosing someone with hypertension. So, as you can imagine, some people are off the radar for 5 years, 10 years. They haven't seen a doctor in a very long time. Perhaps they've been living with hypertension for a very long time. And we want a snapshot of what's happening then and there that may have been resulting from years and years of blood pressure that's been high and that's not been known. So we want to do a really full, thorough assessment of these patients, look for other evidence of organ damage on physical exam. We want to really talk to them and find out what's going on in their life, what's changed. Maybe there's a stressful thing going on over the past couple months. Maybe they've started new medicine over the counter or a prescription medicine that could be impacting their blood pressure. That long list of what we see in about 5% of people with causes of secondary hypertension, we want to evaluate them for anything that we are suspicious for. And I think one of the big ones I'll highlight there is, again, when I'm seeing someone in clinic and I'm identifying new hypertension, one of the low-hanging fruit is to look for sleep apnea. So are they someone who snores? Do they have, when I examine, do they have a crowded airway? Or are they someone who's potentially got hypertension just from sleep apnea that's not being managed? I think that's one of the easiest things I can identify in my patients. A physical exam, of course, thorough for everything else, but specifically some attention to the eyes to look and see if there's any changes to the blood vessels that I described before that could be signs of early damage to the eyes from potentially years of uncontrolled high blood pressure. And then assessment of some things. You may be wondering why your doctor's ordering a few tests on you if you have high blood pressure. We want to get a look at what's happening to the kidneys. If we check a serum creatinine to give us a sense of that. And a urinalysis may also give us a clue that if there's any damage to the kidneys that's happened in the short term or the long term. Electrolytes may give us some clues about other potential secondary causes of hypertension, things related to hormone disruptions or imbalances, and so that may give us a lot of insight there. Now, some of the things lower on this list, fasting blood sugar, we want to, when we're diagnosing someone with hypertension, we want to get that snapshot of what their risk for cardiovascular disease is. And so get a sense of, are they pre-diabetic or are they diabetic and that hasn't been diagnosed? We want to know what their cholesterol profile is. We want to check the rhythm of their heart, check the architecture of their heart, and EKG and echo. Again, more information to see what's potentially happened depending on how long we think this hypertension may have been present. How do we manage? One of the easiest things to do is to recommend certain lifestyle changes. The answer isn't always medication, medication, medication. There's things that we can do that may be a little easier than that in my experience, patients are much more amenable to. These are things that are easier to change than having to take a medication once or twice a day. And so for some individuals, very simply, a change in their diet can help at least by a couple of points in their blood pressure. There is evidence that limiting salt intake, particularly sodium when we say the broader term of salt, but that may help reduce blood pressure by a couple of points. There's something called the DASH diet. That's the dietary approach to stop hypertension. This is a diet that's high in fruits and vegetables, low-fat dairy products, whole grains, fish, nuts, much lower in those refined sugar-sweetened products and red meats. And this has also been found to reduce blood pressure by a couple of points. By exercise, we're referring particularly to any aerobic activity can be very helpful. Especially if done several times a week. Weight loss can reduce blood pressure by a couple of points. Cutting back on alcohol consumption can be an easy way to reduce blood pressure by a couple of points as well. And studies have found that actually just educating patients alone on their condition, awareness of their blood pressure problem, and at least more vigilance of checking that at home, and potentially getting patients more engaged in their own care and the management of their blood pressure rather than handing them a medication. This may also serve some benefits. But if we need medicines, there are certain things we want to be mindful of. Now, there's a ton of medications that can lower blood pressure. The list is very long. I'm going to show you a list eventually, but these are the ones that are recommended as sort of that initial first step, depending on who you are and what other conditions you might have. So by that Joint National Committee 8 and the European Society of Hypertension, these are the recommended first steps. There are groups of drugs here, calcium channel blockers, thiazide diuretics, the ACE inhibitors, and what we call the ARBs. I'll kind of detail each one of them separately here. Calcium channel blockers, so there's multiple flavors of calcium channel blockers. We often utilize a group called the dihydropyridine calcium channel blockers. So these dilate blood vessels and have minimal effect on what the heart is doing. And this is typically a good first step if you are African American and have high blood pressure. This has been demonstrated to work well. People can report some side effects. They may get a little bit of swelling in the legs. That's probably one of the most common things that I get reported to me when patients are on this medicine or these medicines. They may get headache or dizziness. Common names you'll hear for this group, amlodipine and nifedipine, are two examples of drugs that work in this way. You've got your thiazide diuretics. Water pill, people tend to refer to that as that. Again, if you are African American race, this may be a good first step, a good first agent to be taking. Not really understood how this works. It involves a little bit of fluid loss, a little bit of that diuretic effect, and somehow this results in a relaxation of blood vessels that helps lower blood pressure. People can get certain electrolyte abnormalities from taking these medicines that we have to be mindful of. They can also see derangements and a rise in their blood sugar or cholesterol, so that we need to at least be on the lookout for that. Drugs like hydrochlorothiazide and chlorthalidone fall into that category. Now the ACE inhibitors, or angiotensin converting enzyme inhibitors, if you are someone with diabetic kidney disease, or if you have non-diabetic kidney disease with maybe some spilling of protein in your urine, this is definitely a good first step to take. This helps inhibit that enzyme. I refer to the angiotensin converting enzyme, and ultimately downstream of that there's relaxation of blood vessels that helps lower blood pressure. People can develop high potassium with this medication, and that's one of the most common reasons I see people stopping this medication and sort of this being blacklisted from them taking it again. So we have to be careful with that side effect. People can also get a bit of an allergic reaction to this. They can develop a cough. They can develop swelling around their lips and their tongue. So we have to, when we start someone on this medication and follow up with them, we want to be watching their electrolytes very closely, things like potassium elevation. Ask them questions about a cough, and they say, yeah, doc, I've had this dry cough for a couple of weeks. For some people, it doesn't bother them. For some people, it does, and for those that it does bother them, we should find another agent that they can tolerate better. Some examples I've listed there: lisinopril, ramipril, captopril, and enalapril. You're seeing a theme here that medications in the same class tend to rhyme. A similar drug, angiotensin II receptor blockers, ARBs, again, it's a lot of the same rules. If you have diabetic kidney disease or kidney disease with some spilling of protein, this is a group that we should start you on. Either this or the ACE inhibitors. So they act a little bit differently, but again, ultimately leading to some dilation of blood vessels that lowers blood pressure. And the high potassium, the hyperkalemia, that can be a big side effect we have to be on the lookout for. Less of an issue, though, with these medications to see cough and angioedema or swelling around the lips and mucous membranes, but just something that we still should look out for. Drugs like losartan, valsartan, irbesartan fall into this group. If we start that one medicine and it's just not doing it, you come back a couple weeks, a couple months later, your blood pressure is still too high. We have to think about what else we can do to help lower that. Maybe you've tried the lifestyle interventions, you've tried changing your diet, you've cut back on drinking, you tried to lose weight, it just hasn't worked. We have to think about adding another agent. And evidence shows that rather than just increasing and cranking up the dose of that one medicine, sometimes it's more beneficial to add a second agent that acts a little bit differently. And this combination therapy tends to be recommended as one approach to try to get the blood pressure to goal. Certain studies, and the things I've listed up here are from a lot of different trials over the years that have demonstrated what works best, what works okay, and maybe what should be avoided altogether. If you take a calcium channel blocker and we add either an ACE inhibitor or an ARB, that's considered very good therapy for, regardless of who you are. That's a good sort of second step. Is if you're on one, try to add the other and see if that helps get the blood pressure down a little bit more. They've found the combination with a thiazide diuretic or an ACE inhibitor or ARB, or plus an ACE inhibitor or an ARB can also be helpful. The reason I say not recommended for ACE inhibitor plus ARB, you've seen from the previous slides the risk for hyperkalemia, high potassium from one of those medications. And they found a lot of risk in being on two of those medications at the same time. So people's potassium can really skyrocket. Their kidney function can also take a hit. And so these are reasons why we avoid using two together from each of those classes. If you're on one, you shouldn't be on the other. And all the things that I mentioned there, one thing I've left off each of these slides is that, of course, by lowering blood pressure, these drugs pose a huge risk to lowering people's blood pressure a little bit too well. So hypotension, very low blood pressure can also make people symptomatic. They may be very dizzy, lightheaded. I have parents who are on blood pressure medicines and they've suffered from those side effects and it's not pretty. And so we have to always warn patients to be on the lookout for that as well. And that's where the home blood pressure monitor can be helpful. Not just to see if your blood pressure is getting to the goal, but to make sure that it's not being controlled too well. And maybe you don't need all those medicines that you're taking. I mentioned there's a long list for things that we can give people to lower their blood pressure. This happens to be a list of some other categories of medicines that have been used. So we don't always follow those rules that I mentioned before. And the reasons for that is other people have other conditions besides hypertension that we need to be trying to manage at the same time as hypertension. So sometimes there's an easy route to managing the hypertension. If they already have something that makes them a good candidate for something else that I've listed here, try that approach and try addressing both at the same time. So certain things that you are probably familiar with, beta blockers, alpha blockers, some that have both alpha and beta blocking potential, alpha agonists like clonidine, other types of diuretics that affect different parts of the kidney than those thiazide diuretics that I mentioned before. And vasodilators like hydralazine that can target the arteries specifically, help in relaxation of that and help lower blood pressure. Just a number of different ways that these medications work, again, with their own list of side effects and that warrant their own conversation when I'm maybe adding a second or third drug to someone's armamentarium to control their blood pressure, things I need to review with the patient each time I add something. And so the last thing I want to just touch on, I'm going to really just hit the tip of the iceberg here because this is an evolving issue, not just in the field of nephrology, but in a lot of other fields of medicine, of what we do about managing blood pressure and how low we're trying to go. What is our goal? I've thrown around that goal a lot in this last hour here of 140 over 90, 140 over 90. If you get below that, that's, maybe you're pre-hypertension, but it's controlled enough. Well, there's a little bit of controversy on this. And obviously, we don't just want to pick a target. Like, what's the point of just picking a target? You want to know that what you're targeting and what your goal is going to be the ideal therapy. Again, balancing the improvement in your risk for complications of hypertension from risk of serious side effects, risk of lowering that blood pressure too much where someone's going to be dizzy and passing out, and that's not good for any of their organs. Different populations, that goal is going to be a little bit different. So I've mentioned 140 over 90. Even in the elderly in my own clinics, patients with chronic kidney disease, I tend to be a little bit more liberal if they're 85 years old and feeling great, and I don't want their blood pressure to be too low. So some parameters have listed maybe in the very elderly, 150 over 90 is maybe a good target. Certain populations, those with chronic kidney disease or evidence of chronic kidney disease on their urine studies, if they have diabetes, we sometimes try to get a little bit lower than 140 over 90. And there's some evidence to support shooting for somewhat lower goals there. And so it's not a one-size-fits-all in what we do with people's blood pressure or what we're aiming for. And again, we always need to measure the benefits versus risks, benefits of getting very intensive blood pressure control and what that's potentially doing by adding a second medication, adding a third medication, what harm is potentially there for the patient who's on that many medicines. And really bringing this to light was some of the results coming out of the SPRINT trial back in the fall. I think this was very widely publicized, and even just in the mainstream news. For those of you not familiar, this was the SPRINT trial, and this really brought to light how complicated it is when we're looking at how aggressively should we treat blood pressure. So this was about 9,000 non-diabetic adults aged 50 or higher. They basically had some high blood pressure and some cardiovascular disease risk at baseline. They put these people into two groups. Either going to go for that goal of keep the systolic top number less than 140, or we're going to go really intensive and try to drag you under 120. Let's see what's better for you. They looked at sort of over the long term, how often are people developing heart disease, stroke, really serious complications from hypertension that I described in the beginning. And they actually ended up stopping this trial early because they saw such a benefit in those that were very intensely controlled, getting that blood pressure really low, under 120, over 80. And so they put the results out of this, and there's been a lot of debate about it ever since. As you can imagine, we're talking about people over the age of 50. Now, if someone's age 50, are they the same as somebody who's 85? Is it fair to put those people in the same category as far as what we're doing, what our goals are for blood pressure? A lot of the debate is no. I mean, that's really not a fair assessment. We didn't have any diabetics in this study, so we don't know in that large population that's affected by hypertension and cardiovascular disease risk, what do we do with them? And speaking from my own experience, I told you about my own parents who have had complications from really aggressive blood pressure management. They've had low blood pressures. They've had issues with that. If I'm treating my own mother or my own father, I'm not sure I'm that excited to aggressively treat their blood pressure when I've seen what it's done before. And so there hasn't really been a universal acceptance of what we do based on these results. And I think it's going to be interesting to see what evolves coming out of this study and other things that happen after all these results have been publicized, to see what we're doing with these goals for blood pressure, if this is going to be changing. And I'd be interested to see when they do JNC9, the next iteration of these meetings to determine what those goals are for different populations and what the ideal therapy, what the ideal target is for blood pressure. I'll be interested to see what happens there and if it changes what we do day to day. Just to wrap things up and summarize some key points here, certainly hypertension has a variety of causes. It's, as I mentioned, very highly prevalent in the U.S. and contributes to a lot of very serious conditions if we're not managing it appropriately. There's a need for proper measurement of blood pressure to actually make that diagnosis of hypertension and not misdiagnose. And many flavors of hypertension that I mentioned, and with all those cutoffs and those boxes that I showed you, clearly a lot of people may have high blood pressure at certain points of the day, and we might not be finding that in clinic. And hopefully we continue to improve ways to identify those people that may be at higher risk for the things that I mentioned. Additionally, this is a very multidisciplinary approach in managing hypertension, not just throw medicines at somebody, but try to figure out what's changed in their life that maybe we can improve their blood pressure by fixing that and potentially eliminating the need for any medicines, looking at other modifiable things like diet, alcohol consumption, things that we can address easily rather than starting someone on medicine. And certainly looking for other causes of hypertension rather than just assuming that it's there and that there's not something else that can be treated in the process. Certainly the goal blood pressures, that we've established, this continues to be a topic of debate. This varies between one patient population and another. And so those exact goals continue to be a topic of pretty heated discussion here in the medical community. And I think to sort of swing back to the title of my presentation, the pressure really is on all of us. So clinicians, researchers, investigators, we still want to get to the bottom of this, to at least recognize the burden that exists with hypertension, the importance that we have in identifying it, treating it, figuring out how much we should treat it, and how much we should lower blood pressure to hopefully, at the end of the day, improve morbidity and mortality related to hypertension and associated complications. And so all that being said, I'd be happy to take any questions.
So when you say that the blood pressures can vary depending on the circumstances, are we talking about vary by a couple points? Are we talking about vary by like 50 points? Or like how confident can you feel in a value?
That's a great question. I wish I had a direct answer of exactly what I would know about that, of certain ballpark range of someone would fall. All I know is from my own personal experience is that when someone first checks in, maybe they've walked right in from the waiting room, they sat down for no more than 20 seconds, blood pressure checked. between that and when I finally see them in the room with a manual blood pressure cuff 20 minutes later after they've been sitting down, rested, that number, top number and bottom number, can vary by as much as 20, 30 points. And so I think it is very circumstantial of what you're doing in the moments before. Are you actively moving around, or are you seated and rested? Is somebody yelling at you? Is somebody honking the horn at you? There's things I think that it can cause very big variations in blood pressure. And I'm sure there's a lot of information out there on variability, and I think certainly more variability in blood pressure is probably not the best thing, as from what I can recall. So great question. I think it's hard to tell just based on one reading, and that's why I do at least a second reading when I see a clinic patient to get a better sense, because it probably varies a lot. Yes?
So I was wondering if you have opinions about like cinnamon tablets and other non-prescription things that they sell over the counter.
So like some of the herbal preparations, and I'm less familiar with those. That's a good point. I can look into that. I'm not familiar with using that as a way to address. But then again, I mean, if something is helping someone get peace of mind, and if it makes them feel better and maybe makes them more relaxed, and I mean, if it's having that indirect effect, I mean, that's a different thing. But as far as medically, I'm not sure that there's necessarily evidence to support that.
Thanks.
Yes?
So does lowering the blood pressure subsequently lower the risk of getting stroke and some of those other things you mentioned? Or is it just fixing blood pressure kind of masking what may really be going on?
And so generally, yeah, controlling the hypertension, getting it to whatever that goal is, or whatever new goals are, come up soon with some of the new evidence that we have. Technically, getting it to goal is what you want. As I mentioned, certain populations, that goal might be a little different if you're diabetic, if you've had stroke before. But obviously, don't want to swing too far the other direction, where I imagine if you have low blood pressure, you're not necessarily at the lowest risk for some of those complications that you mentioned.
In the SPRINT trial,
Yeah.
did lowering the blood pressure also help with stroke, or did it help with it did help with stroke?
My understanding, at least for the composite endpoint, it was lower, I believe, across the board for all the different categories that they looked at. So again, the question with that too is they stopped the trial early, which isn't always the best thing to necessarily just look at one point in time, because if they had finished it, they might have gotten a different result. And so that's also sort of been a discussion point of what we're gathering just from that snapshot at that point in time. We looked at that data and said, there's lower rate. And so I think we're still going to be learning more and more about this, as time goes on, and people look at further studies and try to sort this out. Yes?
So when someone first comes in and the first blood pressure reading is high, you mentioned a couple times that you have to see them several more times before you diagnose and eventually start treating. Is there like a goal for a timeline to start intervening once you have this first screening, which seems concerning?
Yeah, that's a good question. Probably something I could elaborate on is the fact that if I was sort of talking about this in the sense of somebody's like 141 over 91, or like they're barely above. If someone's like 170 over 100 when I see them for the first time, I may be a little bit more compelled to do something sooner than waiting till that third visit. If it's really that poorly controlled, I may want to step in a little bit sooner. There are a little bit of, there's some small improvement with some of these guidelines of, hey, if there's really a need, definitely intervene sooner. So that's one example of, a way where I wouldn't necessarily follow this, I'll see you again, and give you another chance to have that blood pressure lower. So that's one example where I may step in sooner. So it really is tailored, kind of how I separated things into different populations: diabetics, kidney disease, stroke. It's the same thing, patient to patient. No two patients are the same, and I have to look at each individual separately when I make those decisions. Yes?
And is there any research on using meditation to reduce blood pressure?
Using
Meditation.
meditation. And that's real early on, and probably a point that certainly almost could be a discussion piece just for another talk. I mean, I included personality traits there. So people who maybe are more excitable, anxious, certainly anything that's helping that. If meditation is one of those things that, helps someone sort of manage that stress, that's certainly something that I don't know specifically of evidence. Doesn't mean that it's not out there, but I'd be interested to see that as well, if there's been any studies specifically on that, because that's a great point, that there may be other non-pharmacologic ways to manage that I didn't even touch on.
Thank you very
Great.
much.
Thank you.
Hey.